Welcome everyone to the fifth session of our series. I'm Helene Bader, Senior Advisor of Education for Healthy Women. We are so glad you're here and that you took time today out of your day for yourself, especially during this exhausting and stressful week of news. So I'd like to introduce our organization to you. Healthy Women has been committed to creating and disseminating evidence-based and clinically sound health information for women 35 to 64 for the past 30 years. And menopause is one of the topics that is extremely important and relevant to our audience. So we developed this roundtable to answer all of your questions about menopause and bring you information you can use. We have had some wonderful discussions in our past 4 sessions, and if you missed any of them, all of the videos are on our website at healthywomen.org. We also have some really incredible resources for you, articles from our writing team. We have links to podcasts focusing on menopause, such as Bone Talk, The Black Girl's Guide to Menopause, and Menopause Unmuted. And we also have menopause-specific websites from some of our speakers, such as Dr. Mary Jane Minkin's MadameOvary.com, and a website from one of today's speakers, Dr. Barb Dupree's MiddlesexMD.com. So be sure to check out all those great resources and all the other goodies on our website. Finally, we want to thank our sponsors. We are extremely grateful to Astellas for their generous support of this roundtable series, and thank you to Genève as well for their support. Today, we are going to discuss disease risk and menopause, so covering the issues we need to know to keep our whole body healthy. We will talk about bone health, heart health, cancer risk, and how we can understand these risks during menopause. And then we will learn lifestyle methods to take care of ourselves. The experts we brought together today are going to address all these issues and more. I want to encourage everyone to use the Q&A feature to ask questions throughout the webinar, so we will have a rich and engaging conversation. And now I am thrilled to welcome our esteemed panel of experts and today's moderator, Dr. Sharon Allison-Oddie. Dr. Sharon is the CEO of Carlton Inc. and Beautiful Women Inside and Out. And she also serves as Executive Director of the Koshar Healthy Communities Foundation. So now I will turn it over to Dr. Sharon to introduce our panelists.
Hello, everyone. So glad to be here and so very glad that we are talking about something, and Healthy Women has talked about something that we used to whisper about or not talk about at all and just say, you know, the change, or we would actually as women be ashamed that we were going through the change. And so glad that we're having an open discussion, and has an internist in geriatrician by training and one that speaks to thousands of women across the country every year. I never give a talk that menopause does not come up. I could be talking about a right toenail and menopause. Well, is that related to menopause? So glad to be here. And certainly panelists that are experts are going to talk and discuss health issues concerning menopause, which include heart health, bone health, and general menopause questions. So please, the most important questions that I'm going to ask are the ones that you route to us. So please don't be ashamed, ask your questions. We're going to get as many of those answered as possible. We're also going to talk about HRT, hormone replacement therapy, as well as anything related to menopause that you'd like to talk about. I do want to introduce the panel, and we're going to start with Dr. Manish Chalan. And he is an interventional cardiologist who provides clinical consultation and specializes in catheter-based cardiac, peripheral vascular, and structural heart procedures. That's a lot of words, but he's an interventional cardiologist that's an expert, as you will see. He is the founder of Cardiovisual LLC, a free and easy to use medical mobile app designed for healthcare providers to explain conditions to their patients and for patients to learn more about their heart disease and engage better with their providers. So communications is so key. Next, we have Dr. Barb Dupree, speaking of communication. She's a gynecologist in practice for over 30 years and specializes in midlife women's health and is certified through the North American Menopause Society. She currently serves as Director of Women's Health Services at Highland Hospital in Michigan. She is a great communicator and writer. She's authored the book, Fearless Menopause, a body positive guide to navigating midlife changes. She hosts a podcast called The Fullness of Midlife, for which she interviews women about topics related to health, happiness, meaning, and fulfillment. And then finally, Dr. Sabrina Shani is a clinical assistant professor in the Department of OBGYN and Reproductive Biology at Cleveland Clinic Lerner College of Medicine. She is currently a staff physician at Cleveland Clinic, Florida, in the Department of Family Medicine and Gynecology. She also is a North American Menopause Society certified menopause practitioner, and her research interests include the management of menopause and perimenopause in women with an elevated risk of breast cancer, in addition to understanding the benefits of hormone replacement therapy as it relates to, or hormone therapy in general, as it relates to chronic disease. Please, hi, all of the panelists. We're going to get right to it. And the first question I have is for Dr. Shani. Well, actually, it's going to be for Dr. Dupree. How does menopause affect a woman's cancer risk and the age at which she starts menopause?
Well, thanks, Sharon, for the invitation to present on this topic. And cancer risk probably actually doesn't have a lot to do with menopause. Back to menopause is a conversation that enters most of our offices and most of our visits, but actually menopause itself, the event of losing the function of ovaries, probably doesn't have a significant direct impact on cancer risk. What does have a significant direct impact on cancer risk is going to be aging, and then secondarily obesity. And there is a connection between menopause and weight gain. So there, in that regard, there might be some connection between becoming menopausal and having some increased risk of cancer. But primarily, it's going to be just the fact that we're aging. What we understand is that throughout our bodies, cells are making mistakes. We think that happens every day in multiple areas of our body, but our bodies have this remarkable ability to repair cells until they don't. And it's the aging process that impairs that ability to repair a cell, which increases our risk of cancer as we get older. A woman has a 1 in 3 lifetime risk of developing cancer. And specific to breast cancer, that's going to be a 1 in 8 chance of developing breast cancer. So I tell my patients it's either heart disease or cancer generally. As we age, it's probably going to be one of the two of those things that's going to lead to your demise.
Mm-hmm. So the common factor for all of this is really just aging has the common thread. Great information. And Dr. Shani, what is osteoporosis, particularly in the relationship with aging as well, and the risk factors?
Thanks, Sharon. So osteoporosis really literally means porous bone. So bone in and of itself is in a constant state of building up and breaking down. And so normally it's in a nice equilibrium. But what happens in osteoporosis is that that breakdown happens much quicker than the buildup. And there's a variety of different factors that can impact the risk for osteoporosis. So, particular to this conversation, certainly being in a post-menopausal state. The lack of estrogen can have a significant impact on bone health. Most women will lose bone at a rate of 1 to 2% per year for the first 5 years of menopause, and some women can lose up to 20% of bone during that time, so it is pretty significant. Other common risk factors that I tell patients about that maybe they don't even consider are certain medications. So medications that we use commonly for things like acid reflux may have an impact on our bone health. The use of steroids for prolonged periods of time. Women that may have had a recurrence of kidney stones. I mean, there's so many different factors that can influence bone risk. Generally speaking, white women and Asian women are at most risk, or at highest risk for osteoporosis, and African American women we find to have a 50% reduction in osteoporotic fractures. So they're at a little bit of a lower risk, but that doesn't mean that we disregard anybody's bone health across the board. I mean, I think it's important to talk to your doctor and be open and honest about those risk factors and get the bone density screening at the appropriate time.
And what time is that bone density screening that you recommend?
So it will be very dependent on a person's risk factor. So somebody may be getting it much younger than expected if they have, if they've been on prolonged steroids for an extended period of time, for example. Generally speaking, in somebody who doesn't have many risk factors and they go into menopause, I like to get one within 1 to 2 years of the onset of menopause to establish a baseline.
Excellent, excellent. Now, Dr. Chauhan, heart disease, we all know it's the #1 killer of everybody. And we all hope we have a beating heart. But how does heart disease increase when you reach menopause, and why? And does it actually?
Yeah. So thank you very much again. Thank you for inviting me to this panel, and it's really a pleasure to be here with this group. So great question. I mean, clearly heart disease is the #1 killer for everybody, especially women, and globally. There is, as Dr. Dupree explained, I mean, I think that is the process of aging. So women do tend to develop heart disease 10 years later than men, but women also outlive men by about that. So it becomes even more important that you have older women and heart disease being common. So it becomes even more important to be careful and be monitoring for heart disease, especially in women that are postmenopausal. The cardiovascular risk with menopause is really dependent on the physiologic absence of endogenous estrogen. By association, we know that women who have early menopause tend to have later cardiovascular risk than women who develop menopause at the normal age or later in life. So there is some association more than just cancer. Estrogen by themselves tend to have some vascular benefits. We know that lack of estrogen will change the body's fat distribution, the body's response to glucose, the body's response to blood pressure changes. So there is a little bit more association between menopause and cardiovascular risk. And that's why it's important for us as cardiologists to be more, be taking more into fact the menopausal factors that are common for women in evaluating women or risk stratifying women, because these are the true physiologic changes that women go through compared to men. So it becomes more relevant to evaluate the cardiovascular risk in perimenopausal women.
Excellent. Now, I would like, Dr. Chauhan, for you to break down, just for our audience, when we talk about heart disease, sometimes people get a little confused. And so whether that's high cholesterol, whether that's an arrhythmia, the big medical school term for an irregular heartbeat, or that's high blood pressure, because I've talked to women that say, I don't have heart disease, but I'm on 3 blood pressure medications.
Yeah, and that's very important. I think traditionally, when we talk about heart disease, we're talking about coronary artery disease, CAD, or atherosclerosis, or plaque buildup, or the plumbing part of the heart. Mm-hmm. There's the electrical part of the heart, the palpitations, the arrhythmias, which also tend to be more common in women. There's the actual pump part, which is the congestive heart failure, structural, or the valve disease. So when we talk generally about heart disease, we are specifically referring really to atherosclerosis or plaque buildup. The risk factors for that include certain modifiable risk factors such as high blood pressure, high cholesterol, diabetes, smoking. And then there's the non-modifiable or irreversible risk factors, which is age, getting older, family history, and then sex. So male tends to be a high risk. So I think, yes, generally speaking, when we talk about heart disease, the reference is atherosclerosis, just one part of the various heart conditions. And so it's important that women that have symptoms of palpitations, that's not necessarily heart disease, but that is part of the overall heart disease that we want to be factoring in.
So we talk about heart disease, and you mentioned a key word for me, certainly as an internist and geriatrician, and that I'm going to ask Dr. Dupree, to talk about even the association of diabetes, which we know affects you from head to toe, and menopause, and looking at kind of the whole body experience, because we do want to be positive about our body image, but also understand that we have osteoporosis, we have cancer, we have all these other different things. How do you look at it from a holistic standpoint and first hit diabetes?
Well, let me just step back and talk a little bit about how I speak to my patients about menopause and some expectations. My description to women is you have estrogen receptors pretty much everywhere in your body, in your brain, your skin, your bones, your breasts, your blood vessels, your genitals. And for 40 years, this important hormone has been playing a very influential role in managing and allowing you to thrive and do well. And then you have this experience of a fairly abrupt endocrine organ failure. It's really one of the only times humans experience organ failure, so to speak, and we really choose not to do anything about it. But the consequences of becoming menopausal and losing that major source of hormone, estrogen and progesterone, but primarily estrogen. So your body begins some compensatory work on trying to regain and renew and refine ways of operation. But there can be a really difficult transition in there, late perimenopause into early menopause, where women become symptomatic. And as we learned earlier, estrogen seems to be protective to the heart, and there seems to be some protection for type 2 diabetes. Not sure about the mechanism of action. Weight gain, there seems to be some correlation between becoming menopausal and gaining weight, especially weight central obesity, which is what we see as an increased risk for cardiovascular disease. And why that is, probably something metabolic is changing, that all those things converge to put women at greater risk for a number of conditions, but it includes type 2 diabetes and onset of cardiovascular disease.
That's an excellent lead-in from a question from one of our attendees, and that is, and I'm going to ask Dr. Shani to address this, are postmenopausal women harder to medically manage in regards to diabetes and cardiovascular health?
That's a good question. So, it's really dependent because, as Dr. Chowan had mentioned earlier, cardiovascular disease kind of encompasses many different risk factors. So being necessarily postmenopausal and the lack of estrogen, which we, had touched upon is somewhat cardioprotective, isn't the whole picture. So it depends on family history. It depends on smoking. It depends on what her cholesterol may be, or her, diabetes marker, such as her A1C. So I think it would probably be more dependent on the individual person and their individual risks. I wouldn't necessarily say that postmenopausal women in general are harder to manage. So.
Mm-hmm. Now, lifestyle is such a huge issue. And so, Dr. Chowan, can you please talk about lifestyle management for heart disease? And then I'm going to go and ask all, because this is so important, I'm going to ask all panelists to think about this. And I'm going to come to you and ask you the same question. From your area of expertise, what are the lifestyle modifications, very succinctly, that a woman can make? And I think there's probably a common thread that all of us would say, but from your area of expertise.
So yes, I think lifestyle changes is probably the most important thing, especially for women and especially as we get older, both physically and mentally. I think, there's a lot of emotional challenges, and I think the physical activity not only helps your heart, but also helps your emotional status. I think exercise is the best antidepressant out there. So in terms of physical activity, so lifestyle is just not about physical activity, but it also involves diet. It involves exercise, it involves emotional and mental. So in terms of physical activity, the guidelines would say 150 minutes a week. That's about 30 minutes a day, at least 5 days a week, of at least moderate physical activity, brisk walking, bicycling, or at least 75 minutes per week of heavy, vigorous exercise. So if you were doing some sort of aerobic exercise, swimming, running, so that's the physical activity part. I certainly emphasize a lot on the emotional and the mental part. So, yoga, meditation, those kind of things are important, especially as we get older. I think in terms of the diet, maintaining a healthy weight. Now, again, as we get older, it becomes harder to lose weight, but there is a relatively optimal weight for everybody. Not everybody has to have a BMI of less than 25, but that's an ideal, that's a goal. But I think customizing, as Dr. Sani explained, customizing to the needs of each individual is important. So there are people who are trying really, really, really hard to lose weight, and they reach a point where you've never been that light in your life. You can't try to get an ideal weight just because it's a number. So I think getting a healthy weight that's manageable, that's maintainable, that's, I think, more important. And giving some realistic goals to everybody, to patients, and working with them over time, I think that's important. So, I think lifestyle change is sort of a comprehensive sort of a package, not just one thing or just one kind of exercise. So I think that's something to emphasize and cater to individual patients.
Excellent. Dr. Dupree, you talk a lot about navigating midlife changes, and I'm sure the navigation, a huge part of that is lifestyle. So again, succinctly, when we're in this part of our life, what are the changes that women should adopt?
I think you're going to be hearing some repetition here, because I tell women, if you can put all your effort, eggs in one basket, it's probably going to be exercise. In my mind, exercise and stress management. Exercise helps with stress management, but exercise also promotes sleep. We know there's a direct correlation between breast cancer risk and women who exercise, even irregardless of weight. Obesity being a risk factor for breast cancer in and of itself, but even those women who may be obese but exercise regularly can significantly reduce their risk of breast cancer. And I think just the symptoms of menopause, when it comes to, we lack some of the science to necessarily say you're going to have fewer hot flashes if you exercise, you're going to, for instance, have fewer direct menopausal symptoms. But generally speaking, exercise is great at improving quality of life. One of the big disruptors of the menopause transition is going to be mood. We absolutely see an increased risk for women to be more anxious, irritable, depressed. Back to our, how can we help women best address that? It's going to be exercise.
And then finally, and I know that we're kind of hitting on the same areas, but Dr. Shani, do you have anything to add with lifestyle modifications, and particularly around, let's also talk about bone health as we started this, and lifestyle modifications, particularly diet and nutrition?
Yeah, I mean, so not to sound like a broken record, because again, I think all of these points have been really valid. I've been hearing a lot, especially in the last 6 months, women are coming to see me and they're talking about increased weight gain as a result of quarantine and not certainly being as active as they used to. And so the first thing I say, in this unprecedented time, we need to give ourselves some grace here, where this is unnavigated territory. But I tell women, because a lot of them ask me about these fad diets. Should I do keto? Should I do paleo? Should I do all of these things? And I tell people the best diet is going to be one that you stick to and that is lifelong and sustainable for you. And ultimately, again, my opinion, I don't think it's going to be one of those super elimination diets. I think incorporating a healthy balance of fruits, vegetables, whole grains, lean proteins is really essential for weight management and chronic disease risk. I mean, as Dr. Dupree had mentioned, obesity is a huge factor as it relates to breast cancer. And this is cardiovascular disease, diabetes, hypertension, high cholesterol. I mean, all of this is really related. So, I tell people, try to cut out the processed foods and refined sugars, because if you look at all of these fad diets, pretty much every single one of them cuts out those things, right? So you can do any one you want, but the ultimate underlying theme is that you got to stick to whole foods, fruits, vegetables, whole grains, and lean proteins. Diet, I also think, is increasingly important. We talked about menopause or the lack of estrogen during menopause affecting metabolism in general, but as we age, we tend to lose muscle mass. And so muscle mass is super important in terms of maintaining our metabolism as well. So, going back to things like yoga. So a lot of women think that they have to go to the gym and pump, iron and do all these, heavy weightlifting exercises. Using your own body weight is perfectly fine. There have been studies that even, 5 to 15 minutes of yoga at home can actually help improve bone density overall, to kind of answer your question about bone health. And I'm a big proponent of that. I think, to be honest, before I started medical school, I got my teacher training in yoga. So I'm a big proponent of teaching patients that and helping them kind of through that, because from a mental standpoint and a physical standpoint, I think it's really important.
Excellent. And I do want to just say, as a person that's lost 140 pounds myself and wrote a book, What is that fried chicken wing worth it? Not a diet, a mindset. It is, because my mother makes the best fried chicken. I'm from North Carolina. And when you all talk about, I tell audiences all over, if you're going to restrict something, that means at 4 o'clock in the morning, you're going to go to the refrigerator and inhale every piece of it. And so I believe in balance. And the importance of exercise. I mean, you cannot, and Barb said it, you cannot emphasize that enough. And making sure that there is, as I talk about, the fork and the sneaker balance, that it's not one or the other, but that it is all. And we focus a lot on weight. And as physicians, I'm going to call on us to say, are we honestly talking to our patients about weight, but also, do we really feel like that our patients are having honest conversations with us about weight, and what are those barriers? And we can start with Manish, if you want to start.
Sure. I mean, I think, like Dr. Sani explained, there are the physiological barriers, right? As we get older, metabolism slows down, it gets harder. I think all diets work. It's how well can you maintain, and most diets are very hard to maintain. So again, back to just natural, healthy meals in moderation. And I think a lot of time it's, honestly, it's about having that honest conversation with your providers and being open to what the challenges are. It's easy for us to say what to eat, but it's really when you look at the plate and having literally see what the food is, which none of us really end up doing. And that's the honest expectation that we as clinicians need to have of patients, and patients to be able to honestly share. Well, this is what I eat. I mean, I do have that ice cream every night. Well, I mean, that's a problem. And so I think the barriers are information, of really understanding what diets do. And I think a biggest barrier is also communication with the clinicians. So I think if we can have that honest discussion with our patients, and patients can explain, I mean, I think a lot of things can be met, expected, challenged, taken care of. So to me, in my personal practice, I think that's being open with patients to say, tell me what you really eat. I mean, yes, you don't eat anything. That's what you're telling me, but you do eat, and might as well share with me what you do. And that's how we can then work together.
You all are much nicer than I am, but I honestly say you're eating something. You didn't come, you came here 5 weeks later and you're 25 pounds heavy. You are eating something. And so, but I think it's important for it to be bi-directional. And I don't know, Barb, what you think about doctors actually saying, well, it's hard for me to give up chocolate. What is it that we're doing? And it's not the blame game, but I want to help you. So again, are we being honest? And how can patients help us facilitate an honest discussion? And then should they bring in journals? Should they write down and say, well, what about rutabagas? I mean, what should they do?
Yeah, I think this is it's a great question. And I think different things motivate different people. I think sometimes as providers, we're a little too soft or too nice. We don't want to be harsh. We don't want to come across as being critical. So, we let 3 or 4 pounds a year go by for, 5, 8 years. And here we are 30 pounds later. And now there's hip pain and there's type 2 diabetes and blood pressure is going up. So I do think we as providers just need to try to be more empathetic but honest and blunt.
Mhm.
I had somebody say to me, you know, if you want to be thin, eat like a thin person. And I
Mm.
had the opportunity over the last number of years to be in a number of practices to talk about different topics in the break room. And I will tell you, I can watch a woman walk into the break room and I can predict what she's going to sit down and eat. Either she's 120 pounds or 220 pounds. And it's so remarkable to me that if you want to be thin, eat like a thin person. So I think, you know, bring your thin person out to lunch a few times, watch what they eat or something. I don't know, but it's mysterious to me how year after year you can bring up weight to a patient, and then one year some light bulb goes off and they absolutely adopt what you have been recommending, and they come back and have lost 35 pounds and they feel better and have more energy. But you can have that conversation year after year after year, and then at some point it tends to connect. And I haven't figured out, I think it's more the recipient, the patient, who needs to process and get to the point where they really want to embrace and adopt those changes necessary.
Excellent. And as we round out this part, can we as physicians be honest and say that in our population, among our colleagues, we know, so we want persons listening in to know that, you know, physicians are docs, docs are patients too. I had someone stop me in the grocery store and say, oh my God, you're at the grocery store. And I was like, wow. Who do you think does this for me? And so we have to, if we look at obesity rates in physicians, so we know that this is hard across the board. And then finally, Sabrina, I would ask you to just quickly, there's a question about fat shaming. How do you balance being fat shaming versus saying, no, this is about your health? And there's a fine line there.
It is a fine line.
Culturally, there's a fine line.
There is a fine line. And that was something that I was going to mention earlier, is that, you know, patients are going to be more willing to talk about what they're eating if there's, if it appears to be a judgment-free environment. Okay. So being really open and honest. One thing that I even do, you know, to even relate is I'll tell patients what I eat for breakfast that day. And maybe, you know what, it was an Egg McMuffin on the way to work. Maybe it was oatmeal. Maybe it was a black coffee, right? We are all human beings, like you said, and we all, you know, like it's an 80-20 lifestyle. Everything should be done in moderation. But I think if you come down to a level where they don't feel like you're going to be scolding them or yelling at them, sometimes they open up a little bit more. You know, I also offer alternatives. You know, I pull resources. We have great dietitians, we have great nutritionists, we have people that can really help people, you know, fine-tune their diet and find alternatives and ways to integrate, you know, exercise in their daily lives, because we're all busy, right? So if that means you just park a little bit further at the grocery store to get those extra 50 steps, means you don't take the elevator that day to take the stairs. I mean, all of these things really add up in the long term, and we're so obsessed with this idea of immediate results, right? So we get fixated on this number and we want the results, you know, by Christmas. We want this result by, you know, my birthday or something, you know, some big, you know, occasion or event, or like you had mentioned, like a motivating factor. But the reality is it's a marathon and not a sprint. And so setting that expectation early, I think, is really important for success.
Excellent. And as we wrap up this session, you know, I have 10,000 billion watches as part of my jewelry, but I wear my Fitbit everywhere because I want to challenge myself. And so if we get those steps in, and as I transition to the cardiologist, we know that heart health is important and getting our steps in are important. But Dr. Chowan, this is a question from the audience. We hear about women having heart flutters and palpitations and thinking that they are having heart attacks or panic attacks. How can we tell the difference?
I'm sorry, my lights just went off. So let me just.
We can see you.
It's on a. Okay, good. I'll get up in a second. So heart palpitations by themselves, I mean, these are common. We all have heart palpitations. We just don't often pay attention to it because we're too busy. But the times when you do feel it, it's usually at night, or you're worried, or there's anxiety. So more often than not, they tend to be more related to anxiety, or recognized more when you're in a stressful situation. But palpitations are more of an electrical phenomenon, where you may have some extra heartbeats, or you may have a rhythm problem that there's a little sort of quote unquote short circuit of the heart rhythm. And it just depends on how long it feels. It doesn't always mean it's heart disease or it's related to heart blockages. I think if the symptoms persist, it's important to get evaluated. The commonest things that are triggers are caffeine, alcohol, stress, and 90% of the time, it's reassurance that it's about that. But if people have not been evaluated, then that may be a good time to get your evaluation done. It could start with your primary doctor, it could start with your cardiologist, but it oftentimes is, yes, it's scary when you feel those heartbeats, especially at night, and that keeps you awake, and that stress then leads to more symptoms. But I think most of the times they're fairly benign, but they deserve some sort of evaluation or notification to your primary doctor and take it from there.
And especially if you have coexisting conditions, correct? If you have high blood pressure, if you're obese, if you have diabetes, or you have thyroid disease, which we really didn't hit on, but if you have thyroid disease, it's really important. Now, one of the things that I get asked all the time, and I'm sure you all do, and that is the big issue of supplements. And, you know, there's the latest herb out of Bubba's car that he's selling in a multi-level marketing scheme that is going to take away all my menopause symptoms and cure everything from the Rudy to the Tootie. So what we're going to start first with Sabrina, if you can just hit on non-hormonal management of menopause, and how do the treatments affect disease risk? And then I'm coming to you, Barb.
Okay, so there are a lot of non-hormonal options for the treatment of menopausal symptoms. So I'll first kind of touch on the vitamins and supplements that you had mentioned. Generally, I actually don't recommend a lot of the over-the-counter medications because we don't have a lot of good long-term data on how they affect our body, how they affect chronic disease risk, and some of them have not been shown to be very effective. You know, certainly if a woman is not a candidate for hormone replacement therapy, she has a history of breast cancer, she might have, you know, a history of a significant cardiac history or strokes or something like that. There are a lot of non-hormonal options that can be prescribed by your physician. So most commonly are two medications that are used for depression that we use off-label in the setting to help with hot flashes. They can be administered at lower doses and then titrated up accordingly. There is a medication that can be used that is originally used for overactive bladder that I actually use a lot in patients with a history of breast cancer to help with hot flashes, and it's had pretty significant improvement in reduction in hot flashes overall, especially in women on medications like tamoxifen or Arimidex, which are common endocrine agents to help with breast cancer. You know, and there's a variety of other. I mean, we have one coming up in the pipeline. Hopefully, in the next year, will come to market that I'm really excited about, and so things are growing and the research is really advancing in this area. So if you are not a candidate for hormone therapy, you don't want to take estrogen, and you're really suffering, talk to your doctor about non-hormonal options because chances are we can find something that really helps.
Excellent. Now, Barb, can you hit on on again supplements and what caution they should use or not, if there's the greatest thing since apple pie, tell us.
Yeah.
Yes, I think this is just a really hard area. I had a conversation with I was at a meeting. I was attending a meeting not long ago. It was put on by Mayo Clinic, and they had an integrative physician talking about a number of, and actually it was a breast cancer meeting. It looked into a number of topics, but looking at mindfulness and yoga and acupuncture and all sorts of integrative things. Well, the topic of supplements came up. And at that time, I don't remember which hottest, latest supplement was on Facebook and my patients were asking me about, but I went to the microphone and asked the presenter about this specific supplement and her knowledge of, recommending it or effectiveness. And her comment to me was, there are over 800,000 nutritional supplements in America right now. Mm-hmm. So there is something for everyone. They are all marketed to, claim to achieve something of which we just lack data. We lack data on efficacy, safety. So I think as a provider, it's hard for us to guide our patients because we don't know much more than you do about it. And, you know, what we've seen with the same, you know, marketing schemes that they have seen. But, you know, individuals are oftentimes really eager to find a solution, and they often want a non-prescription solution, so they'll go to that. And frankly, placebo effect. Do not underestimate placebo effect. Almost everything has about a 30% response rate as a result of the placebo effect. So I tell my patients, I wish I could give you more data about effective supplements. I think it's lacking, but if you've tried something, if you find it effective, by and large, they're not going to be harmful. And I can be supportive if you have found it to be beneficial to you. But frankly, we just don't have good data supporting most of what's out there.
And I think for us to be responsible, we have to say, please, even given what the panelists have said about supplements and things like that, please tell your doctor what you're taking. The worst thing that can happen is you have palpitations, you have a cardiac event, and you want to not tell the interventional cardiologist that you've been taking black cohosh or something else that actually could have an effect. And so do tell your doctors what you're taking. And then I'm going to ask as personal privilege, because I tell this to people all the time. I'm on the same page as Barb. I say to audiences all the time, if it doesn't hurt you, and we know it's not on the hit list of bad supplements, then your body will tell you. So for instance, vitamin E, well, the worst thing can happen, you're going to have some nice looking skin. Calcium and vitamin D, we know that you need those, has a supplement. And please, if you disagree with me, do say that. And then I will tell women who ask all the time about thinning hair and those things associated with menopause, a hair, skin, and nail vitamin. The worst thing that's going to happen is you're going to, you know, have a little bit better, brighter skin, but it's not going to really hurt you. But then away from that, you have to be very careful. Anybody object to any of those things?
I don't object. I did want to just make a caveat. So the hair, skin, and nail pill, or the biotin forte, the biotin derivative pills, are really common during perimenopause and menopause as a means to kind of stimulate hair growth. I always tell people, ask me if you're, tell me if you're on it, because if I ever order blood work, and you know, Dr. Chowan can probably attest that it needs to be stopped for 72 hours at least prior to obtaining blood work, because it can totally elevate or lower certain blood levels. So it's really, really important that you really disclose all supplements like you had mentioned. I'm a big proponent of vitamin D3 in women. There's not a lot of good dietary sources as it comes to calcium. I do prefer calcium in the diet. So the recommendation is about 1,200 milligrams per day, which can be, anywhere from 3 to 4 servings of, dairy products, leafy green vegetables, nuts, seeds. That's really important. If you are, a vegan or a vegetarian, B12 supplementation might be really important for you too. You may not be getting that adequately in your diet. So those are really the main ones that I typically recommend. But again, like you mentioned, you really got to reiterate and disclose all kinds of supplements that you're on, so that we can make sure that we know everything.
I will toss this. Oh, I'm sorry. Go ahead, Barb.
We've also seen some association between low D and increased breast cancer risk. So just back to some of the important things that we do want women to get. In my mind, Sabrina, the same, calcium and vitamin D3 are about the only supplements. And I personally tell people those are the only things that I supplement. I happen to live in a place where I get very little sunshine. So I supplement vitamin D3, some of what I do is around helping identify women at increased risk of breast cancer. And for those women, we do look at their levels of vitamin D3 and make recommendations about supplementation if necessary.
Absolutely.
Finally, on vitamin D3, particularly in minority communities, we know that there's a grant. I'm sure you've all seen the data on the word of the day, COVID, and low vitamin D and decrease poor health outcomes. And particularly that is one of the reasons why in two latest peer-reviewed journals, when we talk about health disparities, vitamin D in particularly African-American populations and low vitamin D is really important. And so many of us are preaching, screaming from the rooftop, especially now, to supplement your vitamin D3. And so now I'm going to toss this out to one of you who wants to address this. I mentioned it, but the audience is asking any thoughts on black cohosh. I'm going to try not to say anything. They've heard conflicting info. You can just say yes or no or whatever.
I would say no.
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 Heck no from me. Heck no. Put it down. It's on my hit list. So next question, as we continue to kind of wrap up, and this is a great session. You guys are smart. How do emotional and psychological health issues come up in menopause, especially if you have or are concerned about a chronic disease? How can we manage our emotional health? And this is, I'm going to distill this down. And we've all talked about it, but Barb, I'm going to get this to you. Emotional and psychological health issues come up in menopause mixed with chronic disease. And how can you manage that when you're scared of cancer, you're scared of osteoporosis, you're scared of heart disease, and I'm panicking or I'm depressed?
Great question. Well, I think number one, it's important for women to understand that we recognize the menopause transition to be an at-risk time for mood disruption. Yeah. So sometimes it's just some reassurance that, okay, this is expected. If this is expected, then to me, that's at least somewhat helpful to know. I hand out a menopausal guidebook to women on a new menopausal consult, and it lists things like weight gain and sexual discomfort and sleep and headaches and mood and focus and joint pain and urinary symptoms, and check off the lists that maybe the patient has brought up to me. And my comment is, they didn't print this just for you. They print this because we recognize this as a part of menopause. So again, putting it in the context of expectations. For many women approaching menopause and transitioning through menopause, expectations are so important in how they journey through it. So if they can understand that it's not unreasonable that they're struggling at this point, especially those who've had a history of depression, postpartum depression, PMS, PMDD in the past, we know that they're probably sensitive to hormones and they're probably at greater risk. And then we need to directly address it and make sure that their quality of life, if their quality of life is being impacted by it, we want to figure out how to best address it. And that may be mood-related medications. It may be lifestyle modifications. We may have to see those women more frequently just to kind of support them through that difficult time. But I think we need to recognize that it is necessary to properly address it and treat it. And, coincident with being menopausal, it's dealing with aging parents, it's young adult children, it's job security, it's chronic disease, it's joint pain, it's my new diagnosis of type 2 diabetes. So I think menopause does collide with a lot of other things that happen at that time. So it can be a perfect storm for many women. And I think we just need to understand how we can best walk alongside our patients to support them through that.
Excellent. I like to say, how do you eat an elephant? One bite, one nibble at a time. And you encapsulated it well. It's like everything is coming at us at once. And how do you deal with it? And I think it can be overwhelming when you try to just take it all on. And then finally, how do you differentiate between menopausal symptoms and the realities of aging? And I'm going to go back to Dr. Shani, particularly given what Barb said, is we have all these things going on. Well, is it menopause or is it not? And then, and we have to also be careful with our partners who want to blame everything on either on our period when we're having it or not having a period. But no, you're just getting on my nerves. That's, the other part. That other people blame menopause for everything. But how do you differentiate between menopausal symptoms and the realities of aging?
So, I think it kind of goes back to what Barb said too. It's kind of a perfect storm, that period of time, right? There's a lot of different things that can happen. And I think establishing open communication with your patient to talk about things beyond just these common menopausal symptoms, you know, talk about those emotional mood swings that you might be having. Are they related to work? Are they related to something else going on in life? Are you going through something personal? I mean, I think these opportunities that we have with women during this time, we should really be talking to them about everything, because again, it's the whole picture, right? So it's not just one symptom or one thing that we're trying to do. We're trying to really help the patient as a whole, but it can be very difficult to fine tune some of that stuff out.
Excellent, excellent. I am going to ask now, as we wrap down, for you all to think about what we've talked about. And if there's one thing that you really wanted to hit on, or you want to reinforce for our women on today, and I remind everyone that we have another panel coming on November 18th, and this has been a great series. If you've not watched the entire series, go back to the first one and grab this great information. But give me just a minute or two of final thoughts on menopause. And even before we go to that, I'm going to ask Dr. Manish to challenge to talk about telemedicine and how we can make the best use of it in this new way that we meet with HCP. If you can talk about that and any other panelists, but then give us your closing remarks, particularly on heart disease.
Sure. Thank you. So yeah, telemedicine technology is evolving. And I think we now have an option to be able to interact with our patients and have easier access to patients. It's not for everybody. I think new patients need to be evaluated in person, but I think patients that you've built a relationship, you've had, you know the patient, I think this is a great way to be able to access your professionals, your clinicians. It has made it easy for us on the one hand to get in touch with our patients. On the other hand, sometimes it's a challenge for some of the older folks. But I think, most older folks, they've gotten used to FaceTime. They've gotten used to, being on phones with patients, with their relatives. So I think it is a good option. I don't think it's for everybody, but I think it's going to continue to evolve. Access to care should not be a problem in the day of telemedicine. I think it's similarly with information. There's abundance of information and there's plenty of misinformation. So getting on a telemedicine call with your provider to be able to ask the questions is way better than going to Google and trying to find the information yourself. So I think there are benefits of telemedicine that are going to stay on. I think the reimbursement structure and all those things have helped. And I think, with the COVID pandemic, the way things are, I don't think we're going to get over it anytime soon. But I think, again, for older folks that are at high risk, getting to your doctor, getting to your specialist with telemedicine is a good way. And there are other technologies that are out there, sensors, Apple Watch, that we can access data from patients. And us as clinicians can use that data to better manage patients remotely. So there are lots of tools out there, home blood pressure monitoring, sensors, oxygen meters. I mean, a lot of these things that patients would come into our office, now we can gather that information from home. So lots of opportunities. So not just telemedicine, but technology by itself. The second part of your question in terms of that 1 minute bullet point, I think women go through this physiological period of, 5 to 10 years that are very critical that men don't go through. But women are the decision makers. They are the caretakers for the rest of the family. They suffer the same risk, especially for heart disease, as men. But I think it's very important for us as clinicians to pay special attention to these caregivers, because that woman is taking care of an entire family. And their emotional needs, their physical needs, their medical needs become very, very important. And hence, taking the entire aspect of the woman's care becomes really important. And I think that's working for us as clinicians with the OBGYNs or the primary care doctors becomes even more important in the entire care of the patient. So I think it's a teamwork. I think it's, it's being honest with the patients, and it's giving the full support to the women, especially in those perimenopausal or menopausal years, is really important.
Well, Dr. Chow, and I just want to thank you as a woman and for all women everywhere for you acknowledging that we do run the world and we're the superior sex. Thank you. We appreciate you. Because the only man on the panel recognizing our womanness. So, Dr. Dupree, your 1 minute wrap up.
I would just like to prepare women for what's to come. You know, we all know about the book, What to Expect When You're Expecting, and everybody anticipates before they enter into pregnancy, or many women do, obviously many women do not. But I think if more women have the knowledge of what's ahead before they got there, they could maybe better prepare for the journey ahead, to maybe make that, again, more workable, in that expectations would be understood. So my goal would try to help women be better equipped. So as they enter and navigate it, they will have more answers or know which questions to ask. Because I think for many women, they're experiencing symptoms, for instance, arthralgias. It's up to 50% of menopausal women have joint pain going through menopause, but most women don't associate that with menopause. But if you can have that understanding, so you can talk with your provider about possible solutions. The website I did, middlesexmd.com, was in an effort to help women understand the sexual journey that was ahead of them. Most women don't necessarily know that there are going to be sexual changes that occur as a result of menopause, which in 2 weeks you'll hear much more about. But it's that understanding that knowledge is power, and not everything you read on the internet is fact. So my other goal would be to try to get credible medical information more broadly disseminated to women, to make the best decisions for themselves.
Excellent, excellent. And Dr. Dupree, before we move on, how can we find your podcast? Because I'm looking for that myself. How can we find your podcast?
So The Fullness of Midlife. Mm-hmm. And on the website, Middlesex MD, you can link to it as well.
Okay, great, great, great. Now, Dr. Shani?
Yes, so I would have to say, I think, you know, for a long time, menopause has kind of been it's been associated with a negative connotation that it's the end of one's reproductive years, it's the end of one's, you know, younger years, and now you're kind of entering into this older phase of life. And that is something that I really, really want to try to break, because menopause can be difficult, but it does not have to mean that it's the end for women, right? So like Barb had mentioned, there's a lot of power in education, and I tell women, you have to be your own biggest health advocate. You have to come and you have to go to your doctor and you have to speak up about what you're experiencing so we can best help you. You know, there's a lot of misinformation out there about pretty much everything in the medical world, but certainly around menopause, and you know, safe and effective treatments are available, some not so safe, and treatments are also available. And I caution women to make sure they're getting information from reliable sources. So things like Middlesex MD, you know, North American Menopause Society has great information about everything from menopause to perimenopause to weight changes to osteoporosis, heart health, breast cancer risk. I mean, those are all things that I tell my patients to visit regularly if they have questions, because it can be such a black hole when you go on Dr. Google and try to, you know, Google your symptoms and try to put it all together. But I tell women, be your biggest health advocate. You know, we're here for you, and you know, this is just one stage of life, and it's gonna be real good.
Excellent, excellent. And if you're not ashamed to Google it, you shouldn't be ashamed to talk to your physician, your healthcare provider about it. Not Bubba or Big Mama. Talk to your healthcare provider, because you do have to get good resources and good information. We are wrapping up, and I just want to say thank you to all the panelists. You all were great. And I want to just remind everyone that on November 18th, there is a session that I particularly want to hear about, and that's going to talk a lot about sexuality and menopause. I do a talk called Drop It Like It's Hot and Keep Your Man. A whole issue on sexuality, which is the other whispered thing that women have been, you know, you whisper about. And so why not talk about the two? So please join on November 18th and look at the other sessions that are already here. Please complete the survey and invite other women to the sessions, and go back and look at healthywomen.org. Is a great website to find out anything about being a woman and certainly watch this series. Thank you all for joining us. We have had a great time. Thank you. I've learned something today. I hope you all did too. You all have a wonderful rest of the day.
Thank you.
Thank you.